Andrew,
Joel,
nice to see you again.
good to see you.
Welcome to the podcast. Welcome to my humble abode. I would love to start off with where Dr. Machuk started, and we'll move on from there. So tell me about what's going on in your world.
So, I grew up in British Columbia. I went to the University of British Columbia. When I was there, I took some undergrad, and then I actually did a master's in health administration, which was amazing experience for me because at the same time, I was working at a health economics firm. So I kind of had this dichotomy of experience with business, but also medicine, and then bringing all the science together and how they interact.
All opinions and views expressed by the speakers are not representative of views and opinions of RBC Dominion Securities, Inc. All information and opinions provided in this video are in good faith, but without legal responsibility.
And I was fortunate enough to work with Brian, who is the CFO of our individual firm when I was there. And he helped a lot to kind of bring into context how Canadian healthcare and medicines are basically put into different categories, and how after clinical trials, there's actually an economic trial that takes place in Canada called CADITH. And they basically look at medicines and say, oh, can this be put on the formulary for the individual provinces or as a whole, as a government? And because of the way that the Constitution is in Canada, all of the individual provinces have authority of how healthcare is. So essentially we have all these different 12 models and territories all working differently. And it depends on where you are, how much funding is in that particular model based upon the population. So you technically could get better healthcare in a bigger province than if you're in Prince Edward Island to a certain context. It depends on what drugs are on the formulary. This is why it's so critical and important to note that there are differences between the individual provinces. If you have a very rare condition, let's say, you may or may not have coverage in that particular province. Like, it's hard to know the exact details unless you add the exact condition and the exact medicine. But you know from doing this kind of economic work that it's different in different places in the country.
So interestingly, I think if you were to talk to pretty much any regular voting Albertan Canadian, they would assume that from a healthcare perspective, it would be equal across the board. While Quebec might be slightly different. That I think would be the 30,000 foot view, what most people assume when it comes to healthcare. Mm-hmm. However, what you're suggesting is that like from your background, where you came from, you guys had a different role and you had, firsthand exposure to how each individual province ran, the way in which they differentiate from one another.
Yeah.
So you do this master's and then you decide, I'm going to go to med school. Mm-hmm. Med school happens. You chose a specialty. How did you go about choosing that and why?
So, I think part of the choice came down to the mentors that I had in Vancouver. One of my family friends was an ophthalmologist in town. He was the one that helped me set up housing when I was at UBC. He took care of me when I was there. I was away from my family, and make me dinners, take me to his clinics, just show what he's doing. And I think initially, as my scholastic was good but not great, I thought I had no chance of doing ophthalmology.
Hold on. Good but not great relative to who you're comparing yourself to.
I guess so. I think always, it's important second guess myself and where I am. But I think when I looked at the class in ophthalmology when I was there, you could see that it really came from two different pockets in the country. I was a little bit of an anomaly in where I'm from. I'm small town British Columbia. And then I look at all the other ophthalmologists that does this toric class. And pretty much 99% of the people that were ophthalmologists in my year, at least, Toronto, Vancouver, every single person.
No kidding.
And then they're distributed across the country using this CARMS matching system.
Yeah.
So that kind of comes down to a little bit of randomness. But also it's the way that the healthcare system is set up for better or for worse,
Yeah. Without diving into CARMS, because there's no value in doing that, at least on this podcast.
For sure.
Well, I was kind of separate next to CARMS as it was going on.
Yes.
You were definitely involved, but I think that how physicians are positioned post med school, how residency happens, I think that's something that I wish more Albertans understood a little bit better, because I think it would give a different perception of the special, well, not specialty, but the industry a little bit. I think there might be a little bit more, they'd have a little bit more sympathy. Yeah. And I think that they would understand just how challenging and difficult it is. But kind of expanding on your process of getting to where you are now, it makes a ton of sense why you're here and where you're at. From an ophthalmology perspective, I understand that there's a number of different subspecialties within the specialty specifically.
For sure.
For those that don't know opto, you got eyes.
Yeah.
Eyes are complex, intensely complex. You got retinas, you have all these, whatever. You specifically cataracts. Can you define all the differentiation between the specialty, why it's not all just one,
so
and go from there?
The specialty itself is broken up like all of medicine is broken up. There's different parts of the eye, and people tend to focus on specific conditions based upon those areas. So kind of working from the outside, you have plastic surgeons that work with everything along the face. You have cornea specialists that work on the cornea, the clear windshield of the eye. Then you'd have pediatric specialists that do strabismus muscles and other types of pediatric issues. Then moving back, you'd have cataract and refractive surgeons. And even within the cornea specialty, you can subdivide that into a medical-based cornea specialist and a refractive-based cornea specialist. And you actually go to different residencies as time has passed and the technology is advanced. And then, you could go on to a glaucoma specialist that focuses on the nerve. And then the other side of that would be a neuro-ophthalmologist and then a retina specialist. It's subdivided into those main categories so that you are very, very focused and know everything that's humanly possible and known about those areas. And then you focus on those aspects of surgery. So going to school and taking a residency, you'd learn about everything. And then you'd subspecialize after that in a 1 or 2 year fellowship. And during those fellowships, you may learn to do just 2 or 3 more surgeries for an entire year or two.
It's crazy. The amount of drill down specialty you end up doing in medicine is kind of shocking.
For sure.
It's, someone who's lived through it for 15 years, I kind of have a different appreciation than others might, but it still is mind blowing to me. Yeah, as someone who's in a completely different industry, the type of specialty that you guys go through is unique. It doesn't truly happen in any other industry in my experience, and it's impressive. It's also daunting and whatnot. But from your angle at things, you have your specific specialty. What drove you there? Why that one? Was it opportunity?
I think part of it is serendipity, I would say. When I graduated, my first instance was I want to start a business. So I had talked to a few people in the community, and I got in contact with a specialist that was once a resident, many decades ago, and then moved to Buffalo, New York. And he had 4 or 5 practices that were set up. He was getting older, and he was just a jack of all trades. I walked into his OR. He's doing 30 cataracts. He's doing plastics procedures. He's just doing it all. And this is very unusual for Americans ophthalmologists to do, because they're more subspecialized in their care and then more focused on their area by the way that the residency is. Their residency is totally different than ours. Theirs is a 3-year and then they do a fellowship. Ours is 5-year minimum. Then you can do a special subspecialty, or you could decide not to and just be a general ophthalmologist. That was what I decided to do. Partly so that I could start my family a little bit faster, but also there was different areas that I was very good at in ophthalmology, and I could focus as a subspecialist would on those with the 5 years that I had. So I went to rural Alberta and then worked because the business opportunity and what happened in the the States was, it was very hard to immigrate at the time. Like I couldn't get a visa, even though I had a job for whatever politics were involved. So I went up to Grand Prairie and worked with an ophthalmologist up there who was doing a lot of refractive surgery. So I learned a ton while I was doing that, but also worked with a glaucoma specialist that was subspecialized in glaucoma. And when the glaucoma specialist left, I took over his practice and just did all of the glaucoma work that was up there. I was quite good at retina, so that was one of my stronger areas when I was a resident. So I did all the retina work up there as well.
So you kind of got a broad exposure.
Exactly.
To all the different stuff, and then you
what-
moved past residency. You chose not to specialize, and then now we are basically where we're at today in terms of practice. Because I think most people, when they think about someone who's now graduated through med school, residency, maybe they finish their additional training, they get plugged in at a hospital.
Yeah.
Or when you think about a GP, they buy a practice or they start a practice. I mean, in Alberta, if you choose to be a GP, you have unlimited opportunity in terms of filling your slate with new clients, customers, whatever, however you want to position it. I think if you start to look at all the other specialties, it's like, okay, no, I go and work for the government in some regard. A GP doesn't really, but they're paid for or paid by 3 or 4 different houses, that being like workers' comp, whatever. Ophthalmology, eyes, I think most people, even myself, like how the heck does it happen? Who's paying for what? And is it me? Is it someone else? I think there is a very healthcare, for whatever reason, is incredibly, we don't fully understand how things are being paid for. Yeah. We call it socialized healthcare, or we call it public healthcare, or we call it free. There's so many different definitions. I think anybody who's listens to this podcast realizes that nothing's free. But like, truthfully, how are the lion's share of physicians paid? What is private healthcare and what is social healthcare? If we can break that down before we move past, I'd like to get your side of it, and then we can kind of work through the problem.
So good question. I think when you look at the Canadian landscape, and I specifically talk about ophthalmology, how ophthalmologists are paid is by and large it's fee for service. But how is that healthcare delivered? That's a good question. In general, there's been traditionally either groups of ophthalmologists that have banded together as a business, a private business, and then they function and bill the government fee for service through their practice. Now, in Alberta, at least, there's also departments of ophthalmology where ophthalmologists will do call. And for the most part, up until recently, especially in Edmonton, they were using the facilities to do their operations in the hospital. So then they would bill the government for those surgeries, and they would put just a specific billing code as their facility, but they'd still bill fee for service, and then it would go to their professional corporation. And how those professional corporations are structured is typically the business owner that owns the private clinic would have all of the money going into that professional corporation, and then they distribute the money out to the individual, we call them associates. And those associates would then have their own professional corporation. So they get a percentage, which is actually quite high in Canada comparatively to the American ophthalmologists. The Gini curve, if you'd look at ophthalmologists in Canada, it's incredibly fair the way that the money is distributed. In America, it's not really so. Like most of the time, those practices are looking for associates, and they will pay them a salary to work for the entire year. That's why in America, most of the time when I went there, I was thinking about practice, work for an HMO, work for a hospital, build up your name, build up your practice, then start your own practice. And that's by and large the way everyone was doing things there. As soon as you became like a good surgeon and people trusted you in the community, that was the best way to financial freedom. In Canada, it's almost there's barriers to entry because of the costs of starting practice, but there's also barriers because there's established practices that basically have all of the referrals coming into those locations. So it's hard to really break free of someone else's larger practice and go off on your own. Partly because the barriers to entry, but also partly because just the momentum is going in that direction, and the pay is already good. So you're not going to see many practices just popping up all over the place as new graduates come, whereas in the States it would be much more frequent that that happens and people start their own practices. There's not really amazing economies of scope when you do have your own practice and you have a lot of associates with the current prices, but it is nice to practice with other like-minded individuals that can bring some special skill to the table that you don't do. So from that perspective, I think it's good that the way the Canadian system is, it's a little bit more equal for people and also allows people to bring their own subspecialty to the table.
Okay. Would you be able to attach another specialty that might operate similarly to an ophthalmology group? Like, let's say from my perspective, radiology, perhaps derm. Is there any other specialty that might operate similarly in Alberta or in other provinces?
I think plastic surgery would have some similarities. It's nice to have an OR in Alberta as a standalone with your clinic, although it's more rare. A lot of times because of the complexity of the surgeries, most of the time they're working outside of the hospital. We have this interesting opportunity in ophthalmology where the anesthesia for a lot of the surgeries is very minimal. So getting the surgeries and bringing them out of the hospital has an amazing cost savings for the population and is also much more efficient to be done in a private facility.
Whereas I presume doing any sort of plastics would require significantly more complex anesthesia, and you'd
definitely
have a little bit more risk, etc.
I think where the biggest benefits of ophthalmology surgery has been is the technology has continued to improve, especially in the cataract realm. I mean, even like 4 decades ago, the surgery would take an hour or so. And now I think I can do a cataract in, 5 minutes would probably be the fastest I could do one if it's not complex. And that's because, techniques that have been evolved. And one of them, Howard Gimbel actually invented, it was the capsulorhexis. And that was a game changer for ophthalmology. Before we were doing this little can opening on the anterior capsule to get access to the lens. And then Howard determined that you could actually just tear a perfectly circular rhexis around so you could gain access to the lens and remove it. And then after that, the phaco equipment's become much more efficient at removing lenses. The other nice thing is people are coming in a lot sooner because the lens benefits have been huge for people. Even within the last few years, the lens technology has expanded so much that it's almost become a cosmetic procedure that gets rid of glasses like everyone was doing with LASIK, PRK, and all those procedures.
I want to come back to this part because I think we're moving into where I wanted to question. I had a few questions before because as I was prepping to chat with you, I was learning more and more about lenses, specifically the technology, and just thinking about myself. I had 28 vision as a kid, which is pretty good.
Amazing.
And I don't anymore. I'm much too old to have held on to it. And I notice I can't see like I once did, right? And I was like, oh man, maybe I should do this. I find that advancement and progression socially, or culturally, is an interesting additive to healthcare and where we are today. But reversing back a little bit, I want to talk a little bit deeper about kind of the perception of healthcare in Alberta and Canada specifically that is unique. I think that when you speak to there's anesthesia benefits, the scale that comes with that there's rather a lack of scale because of the uniqueness of the surgery and the process versus perhaps an ENT or whatever it might be that you might see at a traditional hospital. What about privatizing or having more privately operated facilities has benefited you guys, or more broadly, the ophthalmology specialty that has allowed for it to be, I would say, probably the most efficient run subspecialty or specialty that exists right now that isn't currently happening in some of the other surgical realms or specialties,
Yeah.
that maybe there could be some learnings and benefits?
For sure.
Why?
So when I was a health economist, like I did a lot of epidemiology, and I'm looking at the data here. I'm like, okay, everyone's going to be a baby boomer when I'm practicing medicine. What's the most common surgical procedure? It's cataract, by far. It's the most commonly done surgical procedure in the entire world.
Okay.
So there's a lot of people that are going to need it. We're going to have to be efficient in doing this. When I got into medicine and was doing my residency, by and large, in Edmonton at least, and across the other provinces, a lot of the cataracts were done in hospital. It just wasn't...
Makes no sense.
It wasn't efficient at all. Like we were struggling to get like 18 cases done in a single day.
How many cataracts are done in Alberta?
I think it's about 14,000, 15,000.
A year?
Yeah.
Should there be more done per year, or is that kind of just what rolls through?
I mean, I think that before COVID, and this is like one of those seminal moments in healthcare, there was a backlog. And then when the ORs were shut down, the hospitals were shut down, it got really bad. And people also stopped going in to see their healthcare providers. And there was a lot of people that should have had their cataracts done during that period.
Okay.
Then afterwards, and the way this contract worked out with Alberta Health is they wanted to do more privately. I think that's helpful. And I feel like the news that's getting put out sometimes is just completely false. Like there's no way that a private facility isn't more efficient, because for the most part, like in a hospital, and I'm not knocking who's in charge of the hospitals here, but they're not doctors. They don't do the surgery. And if those people are not taking the feedback from the surgeons on how to do things more efficiently because they feel they know better, they don't. Like most of the time when I talk to these, and I was a health administrator, I had the background. When I talk to the health administrators, they don't know anything about ophthalmology. They've never even seen a cataract done half the time. They don't know what it costs. When the nursing contract happened, and I still work in the hospital, all of a sudden there was like 2 or 3 more nurses doing the exact same job. So let me like count out how many people I could have working and do cataracts. More cataracts. I could do more with less. With a single room at my office, 2 nurses and 1 technician, I can easily do 16 to 18 cataracts in the morning. I could do over 30 cataracts a day, easily. When I work in one of the hospitals locally here, they have 3 or 4 people dropping at the front. They have a manager that's there, if not 2 managers that are in the OR. They have an anesthesiologist. I haven't used an anesthesiologist for 5 to 7 years unless it's a very complex case for cataract surgery. Then they have 1 nurse that's actually transporting the patient that's there. And then they have 2 nurses in the individual rooms. There's just no way that you can make that an efficient process because there's too many people that are interacting. It's actually harder to get things done because you can't tell the right person to do the thing that's happening. And if someone's doing something wrong, you don't even know who it is. If something's going awry in my operating room, I just talk to the person that's responsible and then we fix it. Not only that, like you got to think all those people are also getting paid a salary and then they're paying me for the surgery. It's not even close. Like, I don't even know what the number is, but I'm going to say that it's probably like 5 to 6 times more expensive doing a cataract in hospital than it would be in any private operating room in Alberta.
So, like, as a pushback, I think it would be fair to say that with technology, the specific type of surgery you're doing, it's fairly, I think it's fair to suggest that other surgery would not be able to go through that sort of refinement process from an operations and workflow perspective that ophthalmology has been able to attain.
That's correct.
Like preparing somebody for major knee and hip surgery or anything internal, I think is a lot more. I mean, a surgery that's 5 to 10 or maybe 15 minutes versus something that's 7.5 hours. It'd be really challenging, I think, for me to agree, especially with what could happen afterwards.
Yes.
the support staff you need behind it. Like when my reading of doing a cataract, like somebody puts a patch, a couple of weeks later, they can pull the patch off. It's healed up. I mean, the incision's like nanometers.
I have like one good example, and sometimes you have to pick your battles. And this is a clinic that was very successful. It's called the Shoulder Clinic. I think it's in Ontario, and they focus simply on one type of hernia operation.
Okay.
You can pull those ones out that are going to be those anomalies, that they're common enough that you can have the repeatability, that you can take them out of the system, reduce the cost of it, make it very efficient, but also reduce the cost.
Maybe even, what if we were to just pull out healthy people?
Yes.
From our major healthcare system, our hospitals, send them to private.
Yeah.
While our complexity is at our major centers. How much would that to justify? And I don't know.
I think like when it comes down to the healthiness or the not healthiness of the person, it does depend a little bit on the procedure. But what I could pull from the knowledge that I have in other specialties is like, yeah, hernia operations, perfect. What about like scoping shoulders, scoping knees, ACLs, all those procedures that you could basically do on any health level for the most part. You could pull all of those out of the public system because one, they're common. Two, you can reduce the cost, finding the procedures that are the ones that are going to benefit society the most versus just say, oh, plastics does this, ophthalmology does this. Find all the procedures and then just find someone that wants to start a business just doing those things to take the burden off the public system. And yeah, if there's like a big multi-car accident and someone has 14 different fractures, they're very unhealthy. Of course, they need to be in the hospital, and we can focus on those unusual, rare cases that are going to be very complex and expensive and need multiple disciplines in order to solve the problems. Whereas if it's an elective procedure that's very common and lots of people need, like hips, knees, shoulders, cataracts, hernia operations, those have to go out. They have to. They cannot be done in the hospital. And I mean, this is the same thing for, plastic surgeons that are doing cosmetic procedures like women's procedures, breast implants. All these things should be totally out of the hospital. You shouldn't be able to offset your costs as a plastic surgeon taking those private cases into the hospital, because those ones do technically take away from the public sector.
Yeah. The lineup should not be, it shouldn't be longer because you're doing a breast augmentation.
For sure.
Unless it's for some form of
good reason.
Disfigurement, right? So I think it's an interesting concept, and I think the more information people have around this ideology of private versus social or public, the better understanding that we have, the better off we will be as a voting society. And I think that obviously, I from the chair that I sit in, I still don't know enough to possibly give a good opinion on this. It's nice to hear from others that have perhaps different opinions, because you could speak to a physician who operates fully and works within a hospital system like the Alex or the U or UC, whatever, versus somebody who works or operates predominantly private, and they'll have totally different experiences, totally different opinions.
For sure.
And I think that there is obviously some room in the middle, and it would be really interesting to have more public conversations about this stuff so that people can make better decisions and perhaps advance towards some sort of better solution.
For sure.
I think uniquely we're at a point in time from a healthcare perspective where we're going to have so much from a tailwind perspective of benefit from the most recent drug advancements. Like I think Ozempic's going to change the world in a way in which I don't think we fully appreciate yet. And I also I think that from a research perspective, we have artificial intelligence that can run so many simulations on so many different things that is going to allow for so many advancements. But along with that comes like longevity of life, which then is actually an enormous drain on the healthcare system. So we have these like headwinds, tailwinds that are going to change a system that is a massive portion of our budget and is very, very challenging to navigate, but is an incredible opportunity from an investment perspective, a business operations perspective, And for you specifically, as someone who I know you have some interesting business interests and how you want to build what you're currently doing.
For
You got
sure.
an ultra successful practice in Edmonton. I'm noticing that as new advancements come out, people are able to tack them on to their current practice. How have you been able to kind of approach that from an ophthalmology perspective?
I mean, first and foremost, I think people need to adopt new technologies. Adopting new technologies in medicine and all forms of business is the way that we can advance the society. When we get into a situation where technology is not being allowed to be used on the population for health benefits, I think we need to really rethink that and allow ourselves to be open to using new technologies. Within the cataract space, there's been a huge expansion of the number of lenses that are available. Even 5-10 years ago when I started, I think the majority of people were really just doing monofocal intraocular lenses. Those lenses are just for distance for people. They had no reading ability, so everyone needed glasses. The formulas that we're using for measuring the lens power were good, but not amazing, especially for people that are very nearsighted or very farsighted. So the technology is improved in the way that we select the lens to the extent that every single person that we get, there's going to be a lens that can suit them. And to just offer a single vision intraocular lens just doesn't really fit with the technology nowadays. When iHance came out, there was a mid-range lens that would give people the ability to see intermediate vision. So we're talking 67 centimeters on their computer, where a lot of people are doing things with their social medias, computers, phones. Everyone's working at this kind of length. So they had that ability to see intermediate and distance. The multifocal technology, I think, got a bad name because early on, people were trying to experiment with some of those lenses and the results were not as excellent as they could have been, partly because the measurement techniques were not good, but also the lenses were in their infancy. But over the past few years, with the invention of panoptics, things really started coming along where people are seeing very well distance, intermediate, and up close, and were completely glasses free. There were some haloing and glare issues that were associated with those, but those have continually been improved. Johnson & Johnson did a nice job with the Symphony to reduce the glare and halos, but at that time, the reading ability was still a bit weaker on that lens. So then they came out with the Synergy, the next generation lens. I've done hundreds of at this point in time, and again, the reading ability was improved, but the halos and glare were still a problem for certain people. I started to use new technology called eye trace technology. It looks like they're grading visual acuity to help determine if they're going to have problems with these lenses. Part of the problems when you have a multifocal lens is you have these little diffractive surfaces on the back portion of the lens. And then manipulating the eye's natural physiology, when we look at distance, the pupil gets larger and you use the outer portions of those rings. When you converge your eyes and look up close, that's when you're going to use the central portion of that lens. Now the problem comes in, we call it scotopic conditions at nighttime. At night, when there's a bright light coming towards you, like you're driving a vehicle, those lights are going to hit the edges of those lenses. And when that happens, it's going to create glare and halos. And then each individual lens would create a somewhat different pattern, like some would have more crackles through them. And that's how they optically described it. But over time, they've developed ways to moderate those. Firstly, they were trying to smooth the edges, put a like sinusoidal wave into it, just smooth it out so it reduces the diffraction of light. The new version that I just got access to last week is called Odyssey from Johnson & Johnson. From what I can see, and I mean, I know Patricia Pierce, the inventor of the lens, and I've talked to her many times, but they're very cagey about giving the information. But from what I can see of this lens, what they've done is they have a diffractive ring and then they have a secondary diffractive ring. You remember those wave experiments in physics when you had like the two little gates and then the waves would actually cancel each other out. It's smooth. So I think that's what they're trying to do with the new technology to reduce the glare down to as minimal as possible. So I think this is a generational step forward in terms of lens technology. And the people that I've put them in, the few that I've put, have been very happy. This lens has been out in the United States for about a year now. The way that they launched the marketing of this is that they would launch Odyssey the year after they launched PureC. PureC is the upgraded version of the intermediate lens that I was just talking about. So all this technology has come out in the last 5 years, and part of the problem is getting that information out there to the optometry community, but also patients in general, because now the technology is so good. You could be 45 or 50 and say, hey, like I couldn't get LASIK surgery or PRK or even SMILE, but this is a better option for me now because my lens is rigid. I have presbyopia. So even if I got LASIK, PRK, or SMILE, I still wouldn't be able to read. So now there's an option for people pretty much at every area in life where you could get rid of glasses and see better.
So like what drives, I mean, from my perspective, I just care about the investment side. So my thought process here is that, okay, I think about the industries from my perception that have benefited the most from what I would change, or what I would consider to be, we have a reactionary healthcare system to something that's more proactive, someone who is trying to avoid or even be early to different types of preventative medicine. I would determine like this, my eyesight is not so bad that I can't drive, but I'd like to have better eyesight.
For sure.
I think that what we're noticing in men from a specific age group, you have people doing TRT early. They're doing different types of what I would optimization rather than holy man, I feel like crap. My back hurts. I need to go to I need to go to my doctor. I need to go get something done. Right. That is a step function shift in the medical system, which is an interesting opportunity. It basically started with Botox. It feels like, where you have a certain faction of the population that gets something every 2 to 3 months. Filler / whatever. This is a massive industry, massive. It is a huge chunk of people's wallet share. They're spending a lot of money on this stuff. The upper echelons of folks are doing, on the men's side, they're doing like testosterone therapy, that sort of stuff too, from what I can understand anyway. It makes their well, let's call it 45 to 75. They're stronger. They can function better. They can remain 30 for longer, basically, and they're doing it. This is, I think, only going to accelerate. From an eye perspective, I think that is just another thing that, if to me, from an improvement of lifestyle, would have more contribution than almost anything, given that me at 35, I feel like I'm losing my eyesight right now even. I had great, now it's like a relative reduction. It's so bad. It would really help me to add something new. What do you think the opportunity is in eyes? Do you think it's coming or accelerating?
I think there's lots of opportunity, especially in healthcare. Like when you talk about these things and getting older, there's little things that I think our generation are noticing, and we're putting things together in a way that previous generations just put up with. So, I mean, example for me, like recently, like I love steak and I love red meat, and I'm eating it, and like sometimes I'm just feeling like, oh, my stomach's a little bit upset. My wife's the same, like, oh, I don't really like this. One of my good friends, he's a journalist in Las Vegas, but his wife used to be a UFC fighter. So she has access to this company called Thorne, and they do like pharmaceutical and like different kinds of things. And
so like stomach health?
Well, he gave me these pills, and I didn't know what they were at the time when I checked it. He's like, oh, I'm like, man, my stomach's so upset. Like we ate all this food at the Dodgers game. And like, I'm not processing, man. So he's like, just take 3 of these. And it turns out that like I did buy some of them because they were so effective. Like I just took them and I like automatically felt better. I'm like, this solved the problem. And this is just not, it's unusual that like most of the time, like my training is like, oh yeah, it has to be pharmaceutical grade. Yeah, it says clinical trials and everything. All this is like porcine pepsin and enzymes. I think my enzyme levels are just getting a little bit lower as I get older. And the fat content is slowing things down not enough. And I feel upset. But I take these things, I feel better. So I think what I'm saying here is that there's so many areas of medicine that maybe as a doctor you didn't learn in medical school. You have to continuously learn these things and find out where the areas are going to be useful to people. And what I'm finding really useful is the lenses, of course, but also like I think there's an epidemic of people with dry eye, especially in Alberta.
Dry eye.
Irritated, dry.
Are they not wearing sunglasses enough? Like, what's going on here?
Honestly, like the best explanation that I've heard that is a hypothesis is that so you're really focused on something. You focus on your driving, you're focused on your phone, on your social media, or your computer.
Yeah.
Your blink rate goes down a lot, like orders of magnitude lower.
So we don't have our windshield wipers on.
They're not on. Then your eye gets really dry and it feels terrible. It burns. The glands themselves are becoming damaged in people, like prematurely.
Really?
Yes. Like I have a liposcan machine, new technology, and basically there's many different treatments for, we call it blepharitis or inflammation of the eyelid glands. But essentially they get plugged up and then the glandular material comes out in a irregular way. As a result of that, not only are you propagating this by not blinking, but you're damaging the glands that produce the material that prevents evaporation, so it snowballs worse and worse. I'm seeing people like in their 30s and 40s with meibomian gland dysfunction now. Like usually, you see it in older people. You're old and a number of your functions have slowly declined. Yeah. But it's in younger people now too.
Wow. That's super interesting.
Yeah.
So as a total addressable market perspective, from a total addressable market perspective, it feels as though healthcare has expanded, but like if you look at the worst performing sector of the S&P 500, it's healthcare.
It is.
Interestingly, I mean, most recently, you have United Health has gotten smoked. You have most of that's attached to policy, et cetera. But to me, I think if you're looking at momentum and wallet share, health care as a percentage is going, to me, the other direction, where the, let's say, top 25% of wallets will be spending more and more and more on preventative medicine.
Yep.
What that looks like will likely differentiate based on innovation and what actually contributes to better lifestyle.
Yeah.
It feels to me, as someone who has eyesight that's deteriorating, that is a spot that I would justifiably spend some money. I can't figure out why I would do some filler yet. I haven't figured that out yet. It doesn't make sense yet. That does, though. Even something that would maintain kind of body mass, strength, whatever. That to me seems like a very worthwhile thing to spend money on. How do you think you're going to incorporate that into your current business, which feels, I mean, from an outside looking in, Alberta healthcare, you're basically just servicing what's available at the moment. What happens when there's an inflection of people that are interested in preventative medicine versus I'm just servicing people that are blind right now, or rather,
I mean, these are good questions. I mean, you have big conglomerates like United Health, and I think when we think of healthcare, we want to service the whole person. And when we look at like the business aspect of healthcare, there's certain aspects of healthcare that are going to be profitable, but when you group it all together and you have very sick people, like you're just trying to look after that person, whatever the cost, and you're going to lose money on that. So overall, that's why healthcare is not generally a profitable business, because we're basically trying to ensure, like the Bismarck tradition, that you keep the population healthy so they can keep working and live their lives. Like it's a duty to the public. At the same time, there's aspects of healthcare where, yes, you could make like good profits and help people in ways that you weren't helping them before. Perfect example, like me and you, younger guys that want to live a better lifestyle and feel better rather than be like our fathers and just put up with stuff. Like we want to find out what works for us and then be able to do that. Like part of being a physician now is finding those things in the population where there's an unmet need. And you can use new technology to find ways to make these people happy. I think part of the thing I like about doing cataract surgery is there really wasn't much for people in the baby boomers generation to get what they wanted with their vision. Now you can give them exactly what they want, but they still, like, this information hasn't reached that level yet.
There's a big disconnect, I think, without someone who's very interested in drilling down in terms of like even having the time to do it.
Yeah.
If you don't have it, you're not going to do it. And you're just going to assume the system has it covered.
Yeah.
And there is that gap of opportunity that I think is for most specialists available. Like continuous education, you guys all do CE credits, whatever, you go to conferences. But like to incorporate and then to constantly be on the cutting edge is what feels sort of foreign to me, the Canadian market to some extent. But it feels like it's coming and it's here. So talking to you, it gets you a little bit excited. It makes you feel a little less, from my perspective, negative about the overall healthcare system. I'm not somebody who poo-poos on it. I'm not somebody who says this is all broken, it's awful. I'm very much I want to be, I think there's opportunity to make things better. There always is. But generally speaking, we have a very healthy population. It's lives longer than the one in the United States. I'm not sure exactly why that is, but there is obviously contribution from our healthcare system inside of that data. So from my point of view, I think things are quite good. But for you, if you could pick like how, where the opportunity might be most obvious, where would you pick it? What would you identify?
I think I'd have to say that when people get the news and when people are trying to fix healthcare in general, you just have to realize like how incredibly complex and how incredibly different the different specialties are. There's no one solution that fits all. That's why we have a revolving door of people trying to solve the problem. But you need to solve the problem at the individual level. I can solve the problems where I'm working. I can make things more effective if decision makers listen to what I'm saying and the feedback and why I'm saying it. And you can take that information, you can try it with someone that is in the trenches and doing the work. And I'm happy to do that. But I find that most of the time when I try to give feedback to people, it's just not taken seriously. And this is the problem. And this is why I think a lot of doctors are trying to move into a private space, because you can be the primary decision maker. You can make changes for your patients that are going to give them immediate results. They're going to make them happy, that are going to get them service faster. And it's going to make you happier being able to help the people rather than deal with a bureaucracy of 20 other doctors and 10 administrators that have their own thoughts on how to do things. But empowering the physicians in the health system is the key to making things better.
Interesting. I like that. It doesn't necessarily poop on what's currently happening, but it gives you a solution. I like the bottoms up approach rather than what I think has been the political narrative of top down. We're going to replace the top because that's the problem. Truthfully, I think, if you can empower and incentivize, I think that's the key. It's like you show me the incentives and I'll show you the outcome. If you can incentivize those that could rebuild the structure up back to your, we'll call it top-down structure, you might end up having a significantly better result. I think that combined with the two new innovations that we've currently started to see, that being like, I think Ozempic is incredibly impactful. That and AI is going to drive an enormous cost savings in so many different areas that will really benefit our budget. And that makes me less, everyone always talks about the percentage of our budget that healthcare is and how we're screwed. I don't think so. I think that capitalism and innovation always solves our problems, usually just in time, but it does. And so I'm fairly optimistic about it.
I'm reading this amazing book. It's forget the author offhand, but it's called Why Nations Fail, and it breaks down essentially
Ray Dalio.
Not Ray, different one. But it breaks down institutions within society, and it says that if you have extractive institutions that want to take away rights, that want to tax people, that want to take away the free market, you're not going to be successful long term. You got to have a free market. If you want to change things, you can't manage the economy. You have to let people make decisions that are going to be beneficial for them, but beneficial for everybody. Case in point, the contracting situation that's in Alberta right now for cataract surgery. The current system is to make a system of winners and losers based upon, extractive politics and, outright, it could be fraud. There is news out there that is showing that certain people may have benefited from these contracts illegally.
Yeah, it seems like it. Well, at least from what the perception from me is that there are some bad actors, and it's quite clear, obviously, that it's all the rage, and it might not even necessarily be ophthalmology. It's like a few of the surgical locations, but
I can't speak for the other surgical specialties or what's happened, but I can certainly say within the ophthalmology sphere, some funny things happen during the contracting process.
Yeah, and maybe there's some opportunity here. And I think with any new process, which I think contracting is, while not brand newish versus what we would have as like a centralized system, I think that can be improved upon. And I'm guessing as a result of some of this bad press, that will happen and will occur because of the political benefits to continuing is just not there anymore.
I mean, I'm a free market guy, and what I say, if the people want to do hips, knees, and other things, you just tender it to the market and say, this is the price that every single person will get. And if you can't do this price, like, don't get into the game. That way, anyone that wants to be a market entrant into these areas has free will to do so. I think where we could get into trouble in some of these groups is where you get one party that gets market dominance and then not only can raise the prices on the government, but can raise the prices on the individual citizens that are getting the products.
What would you say to, and I think this will be, we're nearing our end to this, what would you say about brain drain into private? Is that an issue? Would you say that there would be a separation?
I think in Canada, it's fairly well balanced. Like me, myself, I do most of my work in my private office, but I still do work pro bono and I work in a hospital so that people can always get the product that they need for no cost.
But if there's no incentive to do it, will people stop?
Because I don't think so. I mean,
are you sure?
I mean, in my perspective, and this is what I truly feel, is that I need to service everybody. If I come across and I'm only doing private stuff, like, yes, I might get like a good volume of people that are coming in for private surgery. But at the same time, I may lose clients because you don't really know what people want until they come into your office. If you're limiting your volume to like this level, people might have misconceptions that you're only doing the ultra premium stuff. I don't do ultra premium stuff only. I like doing that stuff because the technology is very good. We're doing generational new lenses. I'm getting some of the first lenses to use in the country. And that's cool for me because I can help a person that's in that group. But in general, there's not many people in that group.
Yeah.
I want to service the middle. I want to service the middle and something for everybody. And yet I still have people that like have the worst vision possible, super hard to get hold of, but we still service those people and always will. You know what I mean?
I suppose, as me like backpedaling a couple, you look at, there's not enough volume to justify the brain drain necessarily, given how much volume there is to be serviced at the middle of the distribution.
For sure.
So sure, you might lose the world's greatest plastic surgeon from public operation to somebody who only does like ultra famous people's breast augmentation. Yeah. But like, whatever, who cares? At a certain point, that's silly and you don't need that. Truthfully, you can have a really great system as a hybrid. I think kind of what you're thinking.
Yeah. And I think that I take value in helping everybody in every category. It's not like I want to limit my practice just to seeing people that are on this side of the coin. Like there's very, happy people that give me a lot of good feedback in every category. You know what I mean? There's people in every category that, are harder to please too. But at the same time, I don't really like not being able to give healthcare to everyone. That's why I went into healthcare, is to help people and make sure that, people are going to see well. And I just couldn't tolerate just not being able to help everyone in every economic scenario, because the people that need the most help are often the people that are not going to pay you a dollar.
And not only that, I think the return on investment on folks that we service in our healthcare system is not well quantified, and people don't fully understand what you're doing for them. I mean, this would be a whole second tangent that I could go on with regards to taking care of the bottom quartile and how that returns back from tax and all those sorts of things. I think we as a people would benefit from better understanding support systems and the return. So healthcare is one of those things that truthfully does return back. You can see it inside of the Canadian numbers. Well, sure, the last 10 years, we haven't had great efficiency numbers. If you look back over 50, you can see it. I guess from a closing perspective, I think you've shone some really important light onto a very complex healthcare system. And even then we could go on for hours, I think. But you have a specific specialty. You do some really great work. Where can people find you? Where should they look for your practice? And if they want to deal with you specifically, and what can they expect from you over the next 10 years?
So our practice is Visionary Eye Surgeons. We're on Jasper. You can look us up on the web at visionaryeyesurgeons.ca. And even Google search should pull us up pretty quickly there. If you just type in my name, Robert Machuk, ophthalmologist, it should come up pretty easily. I think what's happening for our practice long term is we're moving into some more refractive surgeries. Whether I get a smile machine, which is a new version of the...
That's not for teeth.
Not for teeth, no.
All right.
But it'll make you smile because you see better.
Yeah, okay. All right, so a little bit more... what you would suggest as being something that's earlier to your eyesight issue for folks that want better eyesight, not because they're blind, but because they just want something a little bit better.
Yeah, so I'll open up the practice to the 20 to 40 range. We've been doing a lot of like 50 to elderly for cataracts, but I have a few solutions and new technologies that I think can help people in the space around LASIK, PRK, SMILE, and intraocular contact lenses are a neat new one that we're using more and more nowadays.
Yeah, I surprisingly had more fun looking into the individual business units of the healthcare companies that support the lenses.
Yeah,
that was pretty fun. It's mind blowing to me, all the stuff that J&J provides. It truly is insane, the breadth of their shelf of stuff.
Oh yeah,
it's nuts. But anyway,
Alcon and J&J are the two main players in the space, but there are others, and the European sphere is totally different.
Yeah,
like Zeiss,
Bosch,
Boston Loam, until the recent controversy with their TAS problem.
They were like the OGs, no?
For the most part, yeah.
Okay.
I mean, they're not the biggest player in the lens space, but they're there, full service shop. I think some places don't really get into that sphere because they're not a full service shop. And when I say full service shop, I mean they provide a number of the equipment outside of just the lenses themselves. When you're a small company like a Clarion and you're just providing like 1 or 2 lenses, but you don't provide everything, it's harder as a business to get into them other than just a niche product for an individual person. So like Zeiss is a good company, and they're a company that's been in ophthalmology for a long time, but they're not a full service IOL shop, although they do provide ones for the very, very nearsighted and farsighted people.
Yeah. So I guess for anyone who's like listening to this podcast that is a physician, I apologize for asking patients to look more into their healthcare provider or just what they're going to get done. But because like I think there's a subsect of physicians that hate WebMD. Yeah. But with that said, I think there is some power in doing your own research to an extent, and then making sure that like you couldn't perhaps tailor it a little bit more for yourself. There is an advantage to it. And it seems like healthcare is even going deeper into that realm. And it's super exciting to me.
At this point in time, I know my biggest weakness is marketing and getting the word out there on these lenses. So I'm working on it, like use ChatGPT to come up with marketing protocols and things that I should be doing in order to optimize. I mean, even J&J and these companies are trying to get more marketing to the people to bring information. I love it when patients bring information and have specific questions about the lenses. For the most part, I structure my exams as the first one saying, hey, you have a cataract, we'll put you on the wait list. These are the risks and benefits of your surgery. Oh, and by the way, you have 14 different lenses to choose from. Here's some paperwork.
Good luck.
Please read this over. And then the next visit, we'll scan your corneas using the new technology with iTrace. And then we'll help pick you based upon your lifestyle, based upon what you want to get out of this, the perfect lens for you. So that's how I tailor it. And I think that's what sets me apart from some of the other ophthalmologists in that community.
Or we got to clip that, throw that on the website and go from there. I like that. Well, Andrew, thank you so much for your time. Much appreciated.
Thank
Good
you.
chatting.
You bet.